I want to welcome everyone this morning for Take 10, Transforming Care for Women with Substance Use Disorders and Their Families. This session is going to focus on assessment and screening of co-occurring disorders with Carmela DeCandia. This presentation was prepared for the Great Lakes ATTC under a cooperative agreement from the Substance Abuse and Mental Health Services Administration, or SAMHSA. The opinions expressed in this webinar are the views of the speakers and do not reflect the official position of the Department of Health and Human Services. The ATTC network believes that words matter and uses affirming language to promote the promises of recovery by advancing evidence-based and culturally informed practices. A couple of housekeeping things for you. If you have a technical issue, please individually message me, Rebecca Buller, in the chat section at the bottom of your screen, and I will be happy to help you. If you have questions for the speaker, we're not sure if we'll have much time for questions, but if you put them in the Q&A section at the bottom of your screen, not the chat, that'll help us find them if we have time at the end. If captions or live transcript would be helpful, please locate that option using your Zoom toolbar. You will be redirected to a short survey link at the end of the presentation, and we'd appreciate it if you could fill it out. It takes 3 minutes, and it helps us report back to our funders and improve our offerings. And certificates of attendance will be sent out via email to all who attended today's session in full. If you'd like to know more about what we're doing or information on upcoming events, please see our social media options. And finally, I'd like to introduce our presenter. Carmela DeCandia is a licensed clinical child psychologist who has dedicated her career to advancing best practices and policies to support vulnerable children and families and to improve the systems which serve them. And I'll turn things over to her now.
Thank you, Rebecca, and thank you everyone for inviting and having me here today. I'm happy to be with you. I am sharing my slides, and today what we're going to talk about, as we mentioned, is substance use and co-occurring mental health disorders. As you heard, I'm a clinical psychologist. I do specialize with kids and families, mostly with a lot of trauma work, and also have a specialty in family homelessness. I was the director of the National Center on Family Homelessness for a number of years and ran programs. So in the work that I did, which was very community-based work, there was just a lot of overlap, particularly between trauma and substance use disorder, or trauma, mental health disorders, and even not disorders, but just use in general. So we'll talk a little bit today. And my other specialty is doing testing, neuropsych testing and assessment and screening. And so that's kind of my clinical practice now. And so I've really brought that lens to this topic. And we're going to focus in our short little time today and talking about the issue of assessment and screening. But first, we'll do a little introduction to the topic, and then we'll jump into that. I'm sure I don't have to tell any of you about how common both mental health disorders and substance use disorders are. Statistics show that the majority of people, including ourselves and those in the profession, are affected and touched in some way, if not ourselves, but people we know. I often tell my students at Boston College who are mental health counselors, they're just beginning, that substance use is not something that kind of is on the side of mental health, but these things occur together. And it is important that as a field, we integrate our way of approaching that. So mental health counselors who typically don't get a lot of training in substance use really need to learn how to assess and screen for it, because it's somewhat different than it is in mental health. As I would say, people who work in specialty in addiction who maybe don't have mental health training need to recognize that there are other different ways and other things to look for mental health. So the more we integrate our fields together, the more I think we'll all be able to help more people. But the statistics are staggering for sure. We know that these are an integrated kind of way of approaching is important, because Both substance use and mental health disorders have a neurobiological effect on us. One of the things I do teach is neurobiology for counselors and really understanding the neurobiology of both substance use and mental health disorders. And what we know is that substances will trigger changes in the brain's structure and their function. This webinar, unfortunately, won't go into the neurobiology in depth, but we know that any type of substance will alter the brain. And it alters it in very particular ways that the brain then works to counteract to bring it back to a state of homeostasis. So this is just happens no matter what type of substance, even if you're just having your cup of coffee this morning on a cold morning. The caffeine is a substance. So you're always altering the brain, and depending on what the substance is, the way that substance affects the brain and the frequency and intensity or the strength of that substance, the brain can be affected in dramatic ways. I remember seeing one statistic talking about how you think about food, and food is a substance, but it's different. Even though we can develop a food addiction in a more behavioral way, it's very different than a substance, a chemical substance like a drug or alcohol. Because the potency is very different in terms of its effect on the reward system in the brain, which is about 10 to 12 times stronger when you take that kind of a chemical substance over, say, just sugar. Sugar definitely has an effect on us, but the effect and the potency and the intensity of it on the brain structures, particularly that reward system in our brain that makes us crave and want more of it, is so intense that it becomes very hard to fight this biological impact. So the more we understand the brain issue, the more we can understand how to approach assessment and treatment. The age at the time the person starts or is using is very important, and we see more and more young adults showing very high comorbidity between substance use disorders, mental illnesses, particularly depression, trauma, anxiety, and even schizophrenia to a certain degree. So we see the comorbidity raising, and that developmental aspect of working with young people in their teenage or young adult years is really important to consider, because the young adult brain is a different brain than an older brain. It's still developing. It's still much more vulnerable. And using substances before the age of 16 can be very problematic because of how vulnerable the brain is to the changes. Of course, there are social and cultural factors that lead us to be able to be more vulnerable to stress. But then there's gender. And women have a particular difference than men in terms of our brain structure. Well, the hormonal structure, not the structure of it. The structure is the same, but the way we metabolize certain things is different. The way women respond to certain drugs is different, and we just have different bodies, and hormones are different. So that accounts to a lot of issues. And you can see here that even though men tend to have higher rates of drug use in particular than women overall, both women and men develop disorders at equal rates. So it's not a matter of men do it more, but substance use disorder is unfortunately affecting everyone across genders. And I'm talking here about binary genders in terms of men and women. I don't have the research on what the effects would be on people who may be non-binary or transgender, but that is something where the research really needs to probably get a little bit deeper in terms of our understanding of that. Women metabolize certain drugs differently. For example, women metabolize nicotine faster than men. And so things like patches and smoking replacement therapies sometimes aren't seen as having the same level of effectiveness as they do for men, only because of the metabolism, how women metabolize nicotine, which is different. So women may be more susceptible to craving because of various hormonal issues. So we have to take into account the fact that women use drugs differently, respond differently, and can have unique obstacles, particularly if you are a woman who is parenting and a single mother, where access to treatment, if a woman is the primary person responsible for the child, it is very hard to find treatment that can bring the mother and child together in a 2-generational way. It's the same in mental health counseling programs. And so there's a lot of things that haven't been tested on women, and women have more obstacles to treatment. Women also are more likely to be exposed to physical violence, particularly intimate partner violence. More than 1 in 3 women. Certainly the incidences of sexual assault are very high, and we see rates of over 75% of women who are in substance use treatment programs have a documented history of sexual assault, and that number is probably low. We certainly see that overlap very, very high. We see the same for various ethnic minority and racial minority groups, and gender identity and sexual orientation issues. So we see a lot of additional risk factors just from being women, women of color, and the issues that come with women, often the exposure to violence, which is very high. So if we think about that and we do a little spotlight on post-traumatic stress disorder and substance use disorder as a spotlight of a co-occurring disorder, we really need to be able to look at both of these issues, and we need to assess both, and we need to be able to treat both. We need to understand that trauma may be the precipitating factor for the development of substance use disorder. That may be one thing. It may not be. But for some people, it may be the precipitating factor that led to the development of some kind of disorder. And so we might need to be able to treat the trauma symptoms and the substance use symptoms. For some, substance use is a way to self-medicate trauma symptoms, to try to bring down levels of hyperarousal, to help people feel a little safe, or maybe to help people dissociate and get away from certain memories. So being able to understand the meaning of the use of substances related to the trauma becomes part of the assessment and screening process. What is the purpose of this? And is it at the level of you're using something for self-medication, or has it reached its own level of now it's also a disorder? Substance use will intensify the emotional dysregulation, so it actually can make the symptoms worse. Even though you think they're making them better, it can put you on a seesaw that's increasing or decreasing the hyperarousal, but putting you on a seesaw back and forth. So it's not necessarily, even though in the moment people may feel relief, it's not necessarily helping, because now our brains are getting very dysregulated. Remember, every time you take something, your brain is going to work to do the opposite, to bring it back to homeostasis. So even though in the moment you're feeling a little better, you're creating a swinging effect that's happening. Substance use can also increase exposure to traumatic events. You might be exposed to more high-risk events. We've seen this a lot for women that I've worked with who were homeless or chronically homeless. So people who are living on the street, moving in shelters, they're being exposed in areas where there's just more access, more opportunity to be around substance use. And so that's difficult for them and for their children. And then the things that start getting impaired are very similar. In particular, impaired cognition, impaired thinking. There's so much research on what happens to the frontal lobe of the brain and the connection between the frontal lobe and the emotional system in terms of dysregulation, or the disordered thinking and the disordered memories and the distorted perceptions that start to happen, all in different parts of the brain. There's a lot of good neurological research that shows that both trauma and substance use kind of cause these things, and how much from one or the other is very difficult to tell, but both can really cause kind of a disordered thinking to be kind of almost acquired, right? If you think of someone with schizophrenia as someone who has a organic disorder of a thought disorder, you can think of trauma and substance use as you can kind of get an acquired thought disorder where you're starting to think in ways that are distorted and your perceptions are off, but it's something you've acquired by the illness or the substance use. And there's special issues related to countertransference. Clients and therapists can be deceived. You can try really hard to look good and be very compliant, and things look good, and then people get discharged too early. Therapists have to learn to be cautious, especially mental health therapists who might not recognize the signs that early compliance might be a way to try and hide the substance use. It may be a form of self-protection. I don't want people to reject me for knowing that I'm using. And so there's a dynamic going on, and understanding the countertransference of both trauma and substance use is really important because therapists are at risk in both settings about how countertransference can kind of knock off the therapy and knock off the treatment. And it can happen from both issues. That compliance issue plays itself out both in substance use disorder and in trauma disorders. So it's something we have to watch for. And both diagnoses must be treated concurrently. It's one of the things the research is pretty clear about, is that we have to be careful that we think that if we treat the depression or the trauma, the substance use will naturally go away. Not if it's its own disorder. It may have formed because one thing kind of led to the other, but once we have two disorders, we need to be able to treat two disorders. Otherwise, we're missing something. And in order to do that, we have to know how to assess for both. If we have a co-occurring disorder, and it's assumed, if a co-occurring disorder is assumed when it does not exist, so we think we have depression and trauma, and we assume that, but it doesn't exist, then we could be providing the wrong treatment. We can use the inappropriate treatments. We can expect poorer outcomes. We might provide anti-anxiety medications when that's not the issue. It's really important to get the diagnosis clear and right in both mental health and substance use. If their co-occurring disorder is not assessed and treated, then we might be incomplete in our treatment. We might have missed the substance use. We're treating depression, but we're missing a whole big piece of what's going on for this person because we see it as an outgrowth of mental health and we're not seeing it as its own. So we need to address both, and we need to remember both need treatment. And that means both need assessment. So how are we going to go about that? We're going to do both substance use screening and mental health screening. From a substance use point of view, we want to look at the SBIRT model and combine an SBIRT model with a biopsychosocial mental health assessment to bring together a mental health and a substance abuse assessment, but first have a good screening. And I'm sure some of you are out there are familiar with SBIRT, but in screening, we are using an evidence-based practice to really get a clue if someone is at risk. And we do that by using the SBIRT model, which is a very, many of you I'm sure know, but we're doing brief screening with evidence-based screening tools to identify level of risk. We're not diagnosing, we're identifying level of risk, and it allows you to do a brief conversation to engage the person in, hey, this is what I think is going on, let's talk about treating it. In assessing, there's many ways to do an assessment, and it's a general psychosocial, including a substance use assessment, which I'm going to show you in more detail. We have to bring our biopsychosocial and a substance use assessment together. So first we do the SBIRT, screening, brief intervention, referral to treatment. And the screening measures that are typically used, there are several out there, but we're assessing level of risk, and probably some of you are familiar with the audit or the DAS-10. The audit is the questionnaire to identify risk for alcoholism, and the DAS-10 is the one typically used to identify risk for substance use. There are others for different groups, so it's really important to pick the screening tool that works for the group, like the CRAFT tool, which is particularly good for adolescents, or the TWEAK tool for pregnant women, really like the SMAS tool because it's very good for the geriatric population, because developmentally, and as a child psychologist, I know this, developmentally, we manifest and present things differently based on our developmental stage. So it's really important to use these tools. But if you screen for these and you ask these questions, they're asking about use, type, frequency, duration. And so they're very specific. And depending on how someone answers that, they might screen in for risk or out for risk. That's going to put you in a really good place to go on to do a deeper assessment of the co-occurring disorder. So we do our normal biopsychosocial process, and we assess for history. What are the risk factors for mental health and substance use? Developmental, family, trauma, medical, biological. Do I have a predisposition to something? What is the mental health history? What is my current symptoms? What's the presenting problem, right? A nice, good, full, robust mental health assessment. And if they screened in for alcohol or drug use that is concerning, I will then add my specific substance use fuller assessment. So this is more of an assessment process that will break down, which is really about very specifically looking at use, consequences, treatments, what are the positive gains, and what are the triggers. So we take what we learned from the screening and we break it apart into much more depth. And the difference I find between the two of these models is that substance use assessment is very direct and very specific and got some concrete questions about use. And mental health is oftentimes a little more of an unfolding of letting people tell their story and putting things together. And sometimes we don't ask things in such a directive way as a mental health person. But in substance use, we do have to nail that down, and we have to, because that's part of the assessment process. And so sometimes our training interferes with our approach, and we have to kind of get comfortable with moving back and forth between these two different approaches. So, as I said, there's no single way to assess, but there are a few kind of best practices, and I want to kind of highlight these that you can use. Start with your screener and then your general psychosocial assessment. Get the kind of big picture and get the recurring, what's been going on. They've been drinking, they were depressed as a teenager. Follow it up with the SUD specific questions and use a timeline. And that's one of the kind of things I really want to highlight. If you're going to bring in one new technique into your practice, a timeline will help you identify when things started to happen and kind of what precipitated what. And I'll show you a timeline next. And then you bring that all together to formulate and diagnose, if you're someone who's diagnosing, about whether there's a comorbidity. A timeline allows you to establish the beginning of something and track the evolution of it across two kinds of disorders. So try to determine the chronology, right? What is the early experience? Because we know early experience and early use is a major risk factor. It's also related to psychiatric development of psychiatric symptoms. So you start to kind of chart that and see how are these things lining up. Did the psychiatric symptoms precede the use, the drinking or drug use? And when and what else was going on in the person's life at that time? Or did the drinking and drug use precede the episode of some kind of thought disorder or psychosis or something else happening? That's really important to kind of get a sense of what's affecting what, so you can think about the treatment. And you really have to kind of chart the psychiatric systems alongside each drug or alcohol type use, quantity, and frequency, the duration and consequences. So the thing with substance use is if someone is using one substance, it's kind of easy to track, but oftentimes people are using multiple things. And so you really have to have a really good timeline. Here's a sample of a co-occurring disorders timeline. So here's alcohol, some events in someone's life. You have the age going across the top. This is just one way you can make a table. You can make it in any way that kind of works for your brain. The person was also using opioids, and the mental health issue that was identified was bipolar disorder. So you can see the first drink of alcohol started at 13, and between the 15 and 18-year-old, some weekend drinking. So drinking was kind of progressing from 13 through the 20s. There was some sexual acting out that started in the teen years, and the mood swings started in the teen years. So we start to see a co-occurring happening in that later teen year. And then you start to see the consequences starting to happen, problems at work happening. You start to see some treatment for AA is starting, but then the opioid use started because there was a back issue. So you see one thing might have gone away or been managed, but another thing came up. And you see some stressors going on here with divorces, and then there was a manic episode. So you can kind of start to track how these things are coming together and help people have a better understanding of how things unfolded and then why it's really important to bring that together. So very quickly to wrap up, I want to show you some very specific tools that you can use. This is from Washington and Zebon's book, 2023. I think it's treating alcohol and drug problems in psychotherapy, and they do a really nice piece on co-occurring assessment. So these are excerpts that I use in my class to teach people about ways to do a questionnaire, use some tools. So these are new patient questionnaires to gather a history of substance use. You can see them here: age, time, is it a problem? What was the longest time used? Right? When was the most recent use? So if you notice, we're assessing history of use, Then we're assessing recent use, history and recent. When did people use it? How much was used? And then pretty much some profile questions. Have you ever used more frequently or in larger amounts than you intended to? Have you ever experienced cravings or strong compulsion to use alcohol or drugs? So just some basic questions that go with the recent use. And then you move to consequences. What's been happening as a result of this? And consequences exist on many domains: psychological, sexual, relationship, job or financial, legal. It's not just legal. It's not just I lost my job, but there are psychological ones too. That's the mental health stuff. That's where you start tracking like all these psychological symptoms. And there could be some sexual stuff that's happening alongside of that. Certainly social and relationship things. So you're piecing together this assessment from use to consequences, and then you're looking at treatment. What's been tried? Have they tried anything inpatient or outpatient? And we get a nice kind of overview of that. And then one thing I think is really interesting that people miss is assessing the positive and negative consequences of use. What did people gain, right? It's not all negative. People got something from it, which makes it hard to stop, right? It gives me relief from depression. It makes me stop having these memories. I feel calmer when I'm in a social group. There are things people get from it, and that's the reward system of the brain, wanting that dopamine that comes with using whatever that drug is or that alcohol is to relieve whatever the issue is. It's important to help people identify that they have gained something from this, but it's no longer working, right? The balance is off, out of whack at this point. Physical problems, sexual problems. So there are problems and there are positive, and we need to do both, because if all we focus on is the negative, we're missing a big part of what's working for this person. And that makes it hard to treat and understand and even empathize with how hard it is to let go. You can do an inventory of triggers for recurrence. Some people call it relapse. Some people call it recurrence. Situational ones, internal ones, chemical ones. There's lots of different things you can look at. And make sure we have a good understanding, because we want to set the person up for success. We want to help them understand, how did this develop? How did these two things develop? How is one serving the other? How is one interfering with the other? And then how can we help you move through a recovery process and prevent reoccurrence? Let's identify the things that might be the greatest obstacles for you. And for women, you have to take into account, there might be certain things like, if there's even a mention that my child will be taken away, that's a threat to me. Something with parenting, something with the child, something with safety if they have a trauma history, which is a very big thing. Just being alone in the house. Really important to break apart those symptoms of trauma to recognize them as triggers for substance use. A couple of final thoughts I'll leave you with today. How important it is. I like Kramer's quote here. He writes, "The journey is fraught with challenges as therapists unconsciously participate in the avoidance of affect and the reenactments of core conflicts, characteristics of both disorders." Remember that countertransference. We have to be careful not to unconsciously participate in keeping this thing going. When someone is acting out, it's a loud way to communicate the things that are scary. And so don't be afraid of those loud behaviors, because it's a form of communication. We need to move people towards health, tolerance, containment, and being able to be seen, heard, and understood, which is including being seen, heard, and understood on both disorders. Women with mental health and substance use disorders deserve not just treatment, but compassionate, individualized care that recognizes their unique experiences and challenges. Healing begins with this understanding, not with judgment, and an understanding of the unique things that women bring and the unique ways we can help them in a co-occurring assessment and treatment way. I hope this has been useful for you. I know there's only a minute left, but if there's one question, I'm happy to take it. Otherwise, I wish you all well moving forward in this holiday season.
Thank you so much, Dr. Candia. We are so pleased that you could be with us this morning. And as I've let people know in the chat, we will be posting a recording and a copy of your slides on our website. I'll follow up with an email when I have the access information. and want to thank everyone for being here.
Bye, everyone.